My name is Elizabeth Sherman, and I'm a faculty member with the South Florida Southeast AETC. I'm also a HIV clinical pharmacist with the Memorial Healthcare System and a faculty member in the College of Pharmacy at Nova Southeastern University in Fort Lauderdale, Florida. This presentation is entitled The ABCs of ART, Designing Initial Antiretroviral Regimens for Beginners. This slide set has undergone peer review, and I have nothing to disclose and no conflicts of interest to report. I'd like to acknowledge the UAB Practice Transformation Team led by Dr. Michael Mugavero, the names of whom are listed on this slide. This is the HIV care continuum, and it's sometimes also referred to as the HIV treatment cascade. It's a model that outlines the sequential steps or the stages of HIV medical care that people living with HIV must go through from initial diagnosis to achieving the goal of viral suppression. This module fits into the HIV continuum of care at these steps here. Understanding how to develop appropriate antiretroviral regimens leads to increased numbers of patients prescribed antiretroviral therapy and also effectively suppresses viral replication. The CDC's online compendium of evidence-based interventions and best practices for HIV prevention includes chapters on evidence-based interventions that support important parts of the HIV care continuum. Interventions that help inform this training include the use of telephonic support and text messaging to help bolster medication adherence. This compendium can be accessed via the URL listed at the bottom of this slide. There are 4 learning objectives for this presentation: to list the goals of antiretroviral therapy, which we call ART, and some evidence-based tools for achieving these goals, to review the process of initial ART regimen selection, and in the last part we'll focus specifically on drug interactions, both mechanisms for why these interactions happen and some clinically significant drug interactions with ART. So let's start by reviewing antiretroviral treatment goals and tools for achieving these goals. First, we must remember that HIV is a virus. It's a virus that attacks our immune system cells, and the cells of our immune system are called CD4 T cells. The HIV virus uses our CD4 T cell machinery to replicate, and once it does this, the T cell dies because our cells are not set up to be mini virus factories. So over time, what we see is more and more copies of virus circulating and fewer CD4 T cells. Now, once a person loses T cells, their immune system weakens and they become increasingly susceptible to many opportunistic infections. Antiretroviral therapy works because it stops the virus from replicating, suppressing HIV viral load, which allows for improvements in immune system functioning. This graphic shows the life cycle of HIV. You'll notice that the HIV virus must enter into a person's own CD4 T cell in order to replicate. This entire process of viral replication can be summarized in a few key steps. First, attachment. The virus comes along and attaches to our CD4 T cell. Then entry, where the virus dumps its contents into the T cell. Now, this includes the virus's genetic material, that's called RNA, and viral enzymes. The next step is reverse transcriptase, where viral RNA is converted into DNA. Then integration into the host DNA, which is the integration of the viral DNA into our own DNA. Then viral transcription and translation, and finally assembly of the virion and budding, where this new DNA gets packaged into miniature viruses and is cleaved off of the T cell. And then these new viruses go on to infect other CD4 T cells, and this T cell dies. I use this slide to illustrate for you what happens when a person loses their CD4 T cells. On one axis, we have CD4 count, and on the other axis, we have the time as the disease progresses from months to years. If a person with HIV infection is not on antiretroviral medications, the virus will continue to replicate and the immune system cells will continue to drop. As CD4 T cell counts decrease, a person becomes more and more susceptible to opportunistic infections. So you'll see that with a declining immune system, a person becomes more susceptible to thrush, PCP pneumonia, toxoplasmosis, and many others. And as CD4 count continues to decline, a person becomes susceptible to an increasing number of opportunistic infections. But with antiretroviral therapy, CD4 T cell counts can stay high, and a person can remain free of these opportunistic infections and complications. Current DHHS guidelines recommend ART for all individuals living with HIV, regardless of CD4 count. This is because ART is associated with improvements in morbidity and mortality and a decreased risk of HIV transmission to others. In other words, there are benefits to the individual patient and also public health benefits to the community as well. Now, on a case-by-case basis, ART can be deferred due to individual clinical or psychosocial factors, but ART should be initiated as soon as possible. The goals of ART include getting the viral load, which is also known as HIV RNA, to undetectable, increasing CD4 counts, and as a reminder, a person without HIV infection usually has a CD4 count in the range of 500 to 1500, and an AIDS diagnosis is considered a CD4 count less than 200. This is advanced immune suppression. And other treatment goals include improving quality of life, reducing morbidity and mortality, and as previously mentioned, preventing HIV transmission to others. So here are 3 tools for achieving these treatment goals: performing pre-treatment resistance testing, maximizing adherence, and selecting individualized antiretroviral therapy regimens. So now let me tell you a little bit more about resistance, adherence, and then we'll move into how the process to select an antiretroviral regimen. So we'll start with performing pre-treatment resistance testing. Testing for the presence of drug resistance can help plan therapy. Drug resistance is the reduction of the sensitivity of the virus to a particular drug. Now, this results from a genetic mutation of viral enzymes and proteins that lead to changes in the way that drugs interact with them. There are 2 mechanisms for antiretroviral resistance: transmitted resistance and spontaneous resistance. Now, transmitted resistance is when a person newly acquires a resistant strain of HIV at baseline, at the time of infection. So they're newly diagnosed with HIV, recently acquired HIV, they've never taken antiretroviral medications before, but right off the bat, their virus is already resistant to certain antiretroviral drugs because they have transmitted drug resistance. Now, surprisingly, this happens in about 10% of cases. This is why genotype resistance testing is done always before initiating antiretroviral therapy, because you have to determine if transmitted resistance took place or not. The second mechanism for resistance is spontaneous resistance. Spontaneous resistance occurs because HIV can develop mutations easily and become resistant. One way to prevent the development of this type of resistance is to keep the number of virus particles low by being adherent to antiretroviral therapy. So, as mentioned, resistance testing is recommended for all patients at entry into care to determine if resistant virus was transmitted, and also if a patient fails an antiretroviral regimen to determine if resistant virus has developed. Now we'll talk a little bit about why adherence is so important to treatment success. ART adherence is a major factor in ensuring virologic success and a significant determinant of survival. Adherence to ART has been correlated strongly with viral suppression, reduced rates of resistance, an increase in survival, and improved quality of life. There is also a public health benefit as well. Patients with HIV who are in care on effective ART with a sustained undetectable viral load are less able to transmit the HIV virus to others. A primary goal of ART is full and durable viral suppression to undetectable levels. For most patients, near perfect adherence approaching 100% is necessary to achieve this goal. The goal when taking ART should always be to maximize adherence, but achieving near perfect adherence reduces the likelihood of disease progression, AIDS-related morbidity and mortality, immunologic and virologic failure, and drug resistance. So optimal medication adherence provides by far the best chance for long-term clinical success. Now, adherence is an area where a multidisciplinary care team can really make a world of difference. This includes not just physicians, but mid-level providers, nurses, pharmacists, medical assistants, case managers, and social workers, and peer educators. Adherence to ART can be influenced by characteristics of the patient, the regimen, the clinical setting, and of the patient-provider relationship. There are many factors that are believed to affect a patient's ability to adhere to a treatment regimen. Some are shown on this slide. These include HIV-related stigma, low health literacy, difficulty taking medications such as problems swallowing pills or an erratic work schedule, active substance abuse, and psychosocial factors. As a result of all of these factors, the decision to start therapy is not always obvious, and it's important to address these issues that may bear on adherence before beginning an antiretroviral regimen. Here I've listed some strategies that can be used to improve adherence to ART. Also, a multidisciplinary clinic environment that makes patients feel welcome, comfortable, and respected is important. Clinic staff can assist with reminders of clinic appointments and prompt contact with the patient if an appointment is missed. Clinic staff can also initiate calls to the patient between clinic visits in order to address possible concerns, particularly following the start of a new regimen. Patient education should be supported on an ongoing basis. Patients should be encouraged to identify or develop a network of family, friends, or peers who can encourage or assist them in taking their medications. Patients may also benefit from knowledge of possible adverse effects and when they are most likely to occur prior to starting a new regimen. Clinical staff can share practical tips and encourage patients when to seek attention for issues. We can also encourage patients to use reminder devices such as alarm clocks, cell phone alarms, mobile apps, text messaging reminders, and calendars. Pill boxes are also very helpful. And lastly, regimen complexity and pill burden have been associated with non-adherence. Simple regimens, simplified regimens such as those that incorporate co-formulated agents or once daily dosing are of great help. So there are now 10 available single tablet regimens that are listed here, along with the year of FDA approval starting in 2006. And the most recent single tablet regimens, the single tablet regimens that contain the new Integrase Bictegravir, the new non-nuke doravirine, and cobicistat boosted darunavir being the one most recently approved in 2018. Use of these co-formulated antiretroviral agents and once-daily dosing can reduce pill burden and simplify dosing schedules. These single-tablet regimens, or STRs as we call them, are favored by patients and providers and are associated with better adherence. There are clearly some advantages and disadvantages of single-tablet regimens, though. Sure, they're simple, they're convenient, there are fewer co-pays, and it reduces selective non-adherence to components of a regimen, but there are also some disadvantages to consider. First of all, you can adjust the dosage of the components if you need to do so for drug-drug interactions or for tolerability issues such as renal insufficiency. And they're not available for all antiretroviral regimens and not available for all nucleoside pairs. But here are some of the data supporting the advantages to single tablet regimens over multi-component regimens. There are several cohorts that are summarized here. These have demonstrated single tablet regimens being associated with higher rate of adherence, lower risk of hospitalization, and a lower risk of incomplete dosing or partial adherence. So the next step is going to be selecting an individualized antiretroviral regimen, and that we're going to cover in session 2. But before we get to session 2, I'd like to go over some case studies. So here is case study 1. A 22-year-old man presents for follow-up after recent diagnosis of HIV. He has an initial CD4 count of 390 and an HIV viral load of 46,000. A baseline genotype shows no evidence of antiretroviral resistance. He's motivated to start ART and states he can take medications without issue. Question 1. According to guidelines for the use of antiretroviral agents in adults and adolescents living with HIV, which one of the following best describes the recommendations for starting ART in treatment-naive persons with HIV infection? A. Antiretroviral therapy is recommended for all persons with HIV infection. B. Antiretroviral therapy is recommended only for persons with HIV who have a documented decline in CD4 count of at least 100 cells per millimeter. C. Antiretroviral therapy is recommended only for persons with HIV who have a CD4 count less than 200. Or D. Antiretroviral therapy is recommended only for persons with HIV who have a viral load greater than 30,000. You should recognize by now that the correct answer is A. According to the DHHS guidelines, the following summarizes the key recommendations regarding the timing of initiation of antiretroviral therapy for treatment-naive individuals with HIV infection. Antiretroviral therapy is recommended for all individuals with HIV infection, regardless of CD4 count, to reduce the morbidity and mortality associated with HIV infection. This is an A1 recommendation. And antiretroviral therapy is recommended for individuals with HIV infection to prevent HIV transmission. This is also an A1 recommendation. These guidelines also note that it's important when initiating ART to educate persons with HIV regarding the benefits and considerations regarding ART and to address strategies to optimize adherence. Further, the guidelines point out that on a case-by-case basis, clinicians may decide to defer antiretroviral therapy because of clinical and/or psychosocial factors, but therapy should be initiated as soon as possible. Here is case study 2. A 35-year-old man has been tolerating elvitegravir, cobicistat, tenofovir alafenamide, and emtricitabine, otherwise known as Genvoya, for 3 years, with an often undetectable viral load mixed with episodes of low-level viremia. So viral load ranges in the range of 100 to 300 copies per mil. He reports no side effects, but sometimes forgets to take his medication. He asks if his occasionally skipping doses will cause his ART to fail. So this is a case of a patient who's on a single tablet regimen, one of our one pill once a day complete regimens for HIV, but maybe doesn't have the best adherence. Which one of the following is a consequence of non-adherence to antiretroviral therapy? A. Decrease AIDS-related morbidity and mortality. B. Decrease hospitalization rates. C. Development of resistant virus. Or D. Improved immunologic response. You should recognize by now that the correct answer is C. Consequences of non-adherence to ART include HIV progression, increased AIDS-related morbidity and mortality, increased hospitalization rates, immunologic failure, and development of resistant virus. Here are the references used in this section of the presentation. Welcome to Session 2, Reviewing the Process for Selecting Antiretroviral Regimens. The way an ART regimen is selected is based on a number of factors listed on this slide. We consider regimen efficacy. Now, a typical initial regimen consists of 3 or more drugs from 2 or more classes. Monotherapy is ineffective to control viral replication. We need to use combinations of medications from more than one drug class. We also consider comorbidities such as tuberculosis, liver disease, depression, cardiovascular disease, chemical dependency, or pregnancy. Any comorbidity where there might be a potential for adverse effects or for drug-drug interactions. We consider drug resistance, so if a patient has transmitted drug resistance or developed drug resistance on failure. And importantly, we consider adherence potential. So we consider the total daily pill burden, the dosing frequency, or any food restrictions. We have 5 antiretroviral drug classes, and they're classified based on where in the viral life cycle each drug acts. We have nucleoside reverse transcriptase inhibitors, abbreviated NRTIs, and also called NUCs. Integrase strand transfer inhibitors, abbreviated INSTIs, protease inhibitors, abbreviated PIs, non-nucleoside reverse transcriptase inhibitors, abbreviated NNRTIs, and also called non-nukes, and entry inhibitors. And you'll notice the hatch marks indicating that most patients are likely to be initiated on antiretroviral regimens consisting of combinations of nukes and instis. The PIs and non-nukes are now only recommended in certain clinical situations, and entry inhibitors are not and have not ever been ranked by the DHHS for initial ART regimens. So now let's go back to the HIV life cycle and look at where each of these 5 antiretroviral drug classes work. You'll see entry inhibitors work to prevent the virus from entering the CD4 T cell. And we have 2 types of entry inhibitors, fusion inhibitors and CCR5 antagonists. Nukes and non-nukes work at the point of reverse transcription. They prevent the viral RNA from being converted to a DNA intermediate. Integrase inhibitors work by preventing the viral DNA from being integrated into the host genome. And protease inhibitors work at the final step, preventing the virion from budding off the T cell. This slide shows our currently available antiretroviral medications organized by class. You'll see we have our nukes, non-nukes, integrase inhibitors, and then we also have our pharmacokinetic enhancers, also known as boosters. These are medications that are given concomitantly along with a fully active antiretroviral regimen in order to prolong its half-life and make it last longer in the body. This allows for less frequent dosing and reduced pill burden. The 2 currently available boosters are ritonavir and cobicistat. We also have our single tablet regimens. The single tablet regimens are our 1 pill once a day complete HIV regimens. You'll see they combine 2, 3, or even 4 medications into a single tablet. You'll also notice that every drug has a generic name, a 3-letter abbreviation, and a brand name. And we've had some new drug approvals recently. Single tablet regimens like Juluca, Biktarvy, Simtuza, and Delstrigo have been FDA approved in the past few months. You may have already seen some of the patients that you work with taking some of these medications. So with all of these drugs and drug classes, how do we combine them together? It's pretty simple, actually. The DHHS guidelines tell us to initiate ART with one of these 3 types of regimens: 2 nukes plus an integrase inhibitor, or 2 nukes plus a protease inhibitor, and specifically a protease inhibitor that is boosted, or 2 nukes plus a non-nuke. And as previously mentioned, the PI-based and non-nuke-based regimens are only recommended in certain clinical situations. And remember that boosting is using another drug to increase the effectiveness of an antiretroviral drug. For example, antiretroviral drugs in the protease inhibitor class are often boosted with the drug ritonavir or cobicistat. These interfere with the breakdown of the protease inhibitor, which allows the protease inhibitor to remain in the body longer at a higher concentration. Let me show you graphically what boosting looks like. This is a concentration versus time curve. It's something pharmacists like to geek out on. So on one axis, you'll see we have the drug concentration of the protease inhibitor. And on the other axis, you'll see we have the time from one dose to the next, otherwise known as the dosing interval. When we give an unboosted protease inhibitor, you'll see that the pink line represents this curve. You'll see the drug concentration rises after a person takes the medication and then dips down into the area of potential HIV replication too soon. But by boosting a protease inhibitor, shown by this blue line, by adding ritonavir or cobicistat to it to increase the levels, we're able to increase the area under the curve and decrease the variability in trough concentration. And that's important in HIV because we don't want the virus to replicate and we don't want it to garner resistance. So by adding ritonavir or cobicistat to a protease inhibitor regimen, we're able to extend the drug levels for a longer period of time and make the drug more effective. And per DHHS guidelines, recommended protease inhibitors can be boosted by administering them with either ritonavir, which is abbreviated RTV, or cobicistat, which is abbreviated COBI. So here are the recommended regimens for most people with HIV. in a pictorial display based on the guidelines. The DHHS Guidelines Panel defines these regimens as those with demonstrated durable virologic efficacy, favorable tolerability and toxicity profiles, and ease of use. And again, as discussed, the plan is to initiate treatment with 2 NRTIs plus an integrase inhibitor, and the recommended drug names are listed underneath their respective classes. Preferred NUCs include tenofovir and emtricitabine. Either formulation of tenofovir can be used. Either tenofovir disoproxil fumarate, which is TDF, or tenofovir alafenamide, TAF. Note that TAF and TDF are 2 forms of tenofovir approved by the FDA. TAF, tenofovir alafenamide, has fewer bone and kidney toxicities than TDF, while TDF is associated with lower lipid levels. Safety, cost, and access are among the factors to consider when choosing between these 2 formulations of tenofovir. Now you'll notice back on the slide that in some cases when dolutegravir is the anchor drug, we can use abacavir and lamivudine as our NRTI backbone. The preferred integrase inhibitors include either raltegravir, elvitegravir, bictegravir, or dolutegravir. These are the recommended initial regimens to be used in certain clinical situations. The DHHS defines for us that these regimens are effective and tolerable, but have some disadvantages when compared with the regimens listed in the previous slide, or have less supporting data from randomized clinical trials. However, in certain clinical situations, one of these regimens may be preferred. And again, it is the same NRTI backbone options, either tenofovir plus emtricitabine or abacavir plus lamivudine, combined with either a protease inhibitor boosted with either ritonavir or cobicistat, a non-nuc, or an integrase inhibitor. And the recommended PIs include darunavir or anizanavir, of course boosted with ritonavir or cobicistat. The recommended non-nucs include either efavirenz or rilpivirine. And the recommended INSTI includes raltegravir. Now, of course, raltegravir was on our previous slide list for most people with HIV, but here it is listed again to indicate that it can also be combined with abacavir and lamivudine as the NUC backbone. This regimen is listed here because there is less data to support its use. So now you may be asking yourself, what are the certain clinical situations in which we would use these agents? So the main advantages of abacavir over TDF are that it does not require dose adjustment in patients with renal insufficiency and has less nephrotoxicity and less deleterious effects on bone mineral density than TDF. However, abacavir use has been linked to cardiovascular events in some, but not all, observational studies. Protease inhibitors can be important in those individuals with uncertain adherence, such as those patients at risk for intermittent therapy due to poor adherence, or in whom treatment needs to begin before resistance test results are available, for example, during acute HIV infection, pregnancy, and in the setting of certain opportunistic infections. Few or no PI mutations are detected when a patient's first PI regimen fails, which is not the case with non-nuc and even some INSTI-based regimens. In this context, protease inhibitors such as darunavir may have an important role given their low rate of resistance, their high genetic barrier to resistance, and a low rate of treatment-emergent resistance during many years of clinical experience. In general, boosted darunavir is preferred over boosted atazanavir, but atazanavir also has excellent virologic efficacy in clinical trials and relatively few metabolic adverse effects in comparison to your other boosted PI regimens. However, there was one randomized controlled trial that showed atazanavir had a higher rate of adverse effect associated drug discontinuations compared to either darunavir or the integrase inhibitor raltegravir. Non-nuke-based regimens with efavirenz or rilpivirine may be optimal choices for some patients, although these drugs have low genetic barriers to resistance, meaning it's very easy for the virus to become resistant to these medications. Efavirenz has a long track record of widespread use in the US and globally, and its minimal drug interactions with rifamycins is what makes it an attractive option for patients who require concomitant treatment for tuberculosis. Most efavirenz-based regimens have excellent virologic efficacy, but very high rates of CNS side effects, central nervous system related side effects. So things like abnormal dreams, dizziness, headaches, depression, hallucinations. This is what makes efavirenz-based regimens less tolerable than your other regimens. Now, rilpivirine has fewer adverse effects than efavirenz and is available in one of the smallest co-formulated single tablet regimens, which is Odefsey. It also has a favorable lipid profile. So rilpivirine is a great option for patients who really have a tough time swallowing larger size pills. The drawback to rilpivirine is that it has lower efficacy in patients that have high viral loads greater than 100,000 and low CD4 counts less than 200. And because fewer patients have received raltegravir plus abacavir and lamivudine in clinical trials, and there has not been a randomized trial comparing abacavir lamivudine plus raltegravir to tenofovir emtricitabine plus raltegravir, the panel categorized raltegravir plus abacavir lamivudine as a recommended in certain clinical situations. So when you think about it, the model for selecting an antiretroviral regimen really follows the model of one of my favorite restaurants, which is Panda Express. So before you start laughing, let me tell you why selecting an initial HIV regimen follows what I call the Chinese food. Instead of thinking about this in terms of recommended initial regimens, think about it recommended Chinese food. And instead of 2 nukes, you get 2 scoops of rice. And instead of pairing 2 scoops of rice with either a protease inhibitor boosted with ritonavir or cobicistat, or a non-nuke, or an integrase inhibitor, you can think about it as beef enhanced with MSG, or chicken, or fish. And so just like Panda Express, where you go through the line and you follow a stepwise approach, building an ART regimen follows those same basic rules. First, you get 2 scoops of rice. You choose 2 nukes, tenofovir and emtricitabine, or abacavir and lamivudine. And we try to use co-formulated agents whenever possible to decrease pill burden and improve adherence. And then you move down the line at Panda Express. You choose your one main entree, beef, chicken, or fish. We decide which antiretroviral class to use, protease inhibitor, integrase inhibitor, or non-nuke. And how we make that decision is based on what we've covered previously, comorbidities, pill burden, drug interactions, and resistance testing. So ultimately, antiretroviral selection is guided by the regimen's efficacy, genetic barrier to resistance, adverse effects profile, convenience, the patient's comorbidities, concomitant medications, and the potential for drug-drug interactions. So PIs with ritonavir or cobicistat are like beef enhanced with MSG. Just like beef, PIs are very strong and very potent. It's difficult to become resistant to protease inhibitors. And recall that these regimens are best for patients with uncertain adherence or if resistance tests are not available. However, just like beef, PIs have some metabolic effects. They can raise cholesterol or worsen diabetes. So now let's move on to some case studies. This is case study 3. A 34-year-old woman presents to the clinic to discuss starting antiretroviral therapy. She was recently diagnosed with HIV infection, and her initial CD4 count was 550, and HIV viral load was 88,000. A repeat CD4 count 4 weeks later is 438. Baseline genotype resistance assay shows no mutations that would confer resistance. She is motivated to start therapy and feels she can take medications every day without missing any doses. According to the guidelines for the use of antiretroviral agents in adults and adolescents living with HIV, which one of the following is considered a recommended initial regimen for most people with HIV? A. Rilpivirine, tenofovir, alafenamide, emtricitabine. B. Darunavir, cobicistat plus abacavir, lamivudine. C. Bictegravir plus zidovudine, lamivudine. Or D. Dolutegravir plus tenofovir, alafenamide, emtricitabine. The correct answer is D. According to the guidelines, the recommended initial regimens for most people with HIV is a 2-drug NRTI backbone combined with an integrase inhibitor anchor drug. The choice of which one of the recommended antiretroviral regimen options to use depends on multiple factors like pill burden, dosing frequency, drug interactions, comorbid conditions, and baseline HIV drug resistance test results. The recommended initial regimens for most people with HIV are as follows, and all regimens can be given as once-daily dosing. Dolutegravir, abacavir, lamivudine, which is Triumec. Dolutegravir plus tenofovir, emtricitabine, which is Tivicay plus Descovy or Tivicay plus Truvada. Elvitegravir, cobicistat, tenofovir, emtricitabine, which is Stribild or Genvoya. Raltegravir plus tenofovir, emtricitabine, which is Isentress plus Descovy or Isentress plus Truvada, and Bictegravir, tenofovir, emtricitabine, which is Biktarvy. So of all of the choices listed on this slide, D is the only one that completely represents a preferred regimen for most people with HIV. Case study 4. A 26-year-old transgender man, preferred pronoun he, with chronic HIV infection presents to the clinic for a follow-up visit to start antiretroviral therapy. 2 years prior, he was diagnosed with HIV infection, but then was lost to follow-up. He is now ready to start treatment, and he has a CD4 count of 466 and a viral load of 58,400. He has known diabetes, an estimated creatinine clearance of 56, and a history of depression. No antiretroviral resistance testing results are available. According to the guidelines for the use of antiretroviral agents in adults and adolescents living with HIV, which one of the following options is in the category recommended initial regimens in certain clinical situations? A. Raltegravir plus zidovudine, lamivudine. B. Nevirapine plus tenofovir, DF, emtricitabine. C. Darunavir plus ritonavir plus tenofovir, AF, emtricitabine. Or D. Elvitegravir, cobicistat, tenofovir, DF, emtricitabine. The correct answer here is C. The DHHS guidelines classify antiretroviral regimens for initial therapy as either recommended initial regimens for most people with HIV or recommended initial regimens in certain clinical situations. Multiple possible alternative regimens can be used that are considered effective and tolerable, but have potential disadvantages when compared with recommended regimens. Note that zidovudine and nevirapine are not included in either of the categories recommended for most people or recommended in certain clinical situations. For the patient presented, the only option in the alternative category is darunavir plus ritonavir plus tenofovir, alafenamide, emtricitabine. For individuals in whom treatment needs to begin before resistance testing results are available, for example, during acute HIV infection, pregnancy, and in the setting of certain opportunistic infections, darunavir may have an important role given the low rate of transmitted resistance, its high genetic barrier to resistance, and low rate of treatment emergent resistance during many years of clinical experience. Also, In this patient with mild renal insufficiency, the fixed-dose combination of tenofovir, alafenamide, emtricitabine is an option. Tenofovir alafenamide can be used without dose adjustment if the creatinine clearance is at least 30 mils per minute, but the dose of emtricitabine requires dose adjustment if the creatinine clearance is less than 50. Option D, which is Stribild, should not be initiated in patients with creatinine clearance less than 70 mils per minute. One of the reasons for this is because it contains TDF. Here are the references used in this section of the presentation. Welcome to session 3. Now we'll move on to talking about drug interactions. This is my favorite part as a pharmacist. Specifically, I'll review the mechanism of antiretroviral drug interactions and how to identify antiretroviral medications with a high potential for drug interactions. Antiretroviral drug interactions can occur when there are alterations in drug absorption, distribution, metabolism, or elimination. Now, absorption occurs in the gut, so this can be affected by changes in gut pH or gut motility. Distribution is when drugs distribute to tissues, so these can be affected by changes in volume, such as pregnancy, and by drug displacement. Metabolism mainly occurs in the liver, and this is where most antiretroviral drug interactions occur because of changes in hepatic drug metabolizing enzymes like cytochrome P450. P450 is a liver enzyme family that breaks down drugs into smaller molecules. And you'll see on this slide that the P450 drug metabolizing enzyme influences and is influenced by many antiretrovirals and many other drugs. Importantly, PIs, non-nukes, maraviroc, integrase inhibitors, and cobicistat can be P450 substrates, inducers, or inhibitors. A P450 substrate is a drug that's metabolized by the liver's P450 enzyme. A P450 inducer is a drug that induces the production of the liver's P450 enzyme. And a P450 inhibitor is a drug that inhibits the liver's production of the P450 enzyme. I'll show you what this means on the next few slides. And remember, the P450 enzyme is what's responsible for breaking down other drugs, so this in turn causes many drug interactions. Lastly, the last step of pharmacokinetic transformation is elimination, which mainly occurs in the kidney. So now let's get back to that P450 business. This is how everything is supposed to work in the body, okay? So the function of the P450 enzyme in the body under normal circumstances. You take a drug, the drug goes to your liver to be metabolized. In your liver is a P450 enzyme, and this enzyme breaks down the drug. So the drug is useful for a certain amount of time. So here's your concentration versus time curve. You see that the drug is active for a certain period of time and then it trails off. And this gives you a happy patient. Now there are two things that can go wrong here. You can add another drug that's an inhibitor of P450, or the opposite can happen. You can add another drug that's an inducer of P450. So this is what happens when we inhibit P450 with another drug. So you take your first drug from the first example, but now you take a second drug with it, and this second drug happens to be a P450 inhibitor. Because it inhibits the production of this enzyme, you're blocking the enzyme. Now the enzyme isn't available to help break down your first drug. So our focus drug stays active in the body for too long, and toxic events can occur. Now, obviously, the opposite can happen. You can give your first drug with another drug that's a P450 enzyme inducer. The inducer increases production of the enzyme in the liver. So now you have more enzyme available, breaking down drug even faster, and you break it down before it even has any opportunity for full efficacy. This slide shows the 5 antiretroviral classes and how they're metabolized in the body. But what I'd like to call your attention to are the drug classes at the center of the slide: non-nukes, PIs, and integrase inhibitors. These all influence or are influenced by that P450 enzyme in the liver. This means that these medication classes have the highest risk of drug interactions, and as you'll recall, first-line ART usually combines 2 nukes nukes plus either a non-nuke, a PI, or an integrase inhibitor. So our patients that are on guideline recommended antiretroviral therapy are often at risk for drug interactions. So let's review some clinically significant drug interactions for patients on antiretroviral therapy. And these are just a small sample of some of the common classes of medications that have significant interactions with antiretroviral medications. Cholesterol meds, anti-acid therapies, meds for tuberculosis, hormonal contraceptives, some of our asthma inhalers, specific seizure medications, medications for hepatitis C, which is a commonly occurring co-infection in our patients, erectile dysfunction medications, and even some herbal supplements and other antiretroviral agents. All of these can interact with ART. So as you can see, patients on ART are often at risk for drug interactions because so many of our patients are taking medications that would be on this list. So it's important to always ask each patient if they have had any medication changes at each encounter and counsel them to notify their prescriber's office of medication changes. If patients are getting all of their medications from a single pharmacy, then the pharmacist is also checking for interactions when medication lists change. So now what I'd like to do is focus on the two biggest drug interactions that I see on a daily basis. And these are drug interactions between antiretrovirals and cholesterol medications and anti-acid therapies. The cholesterol medications are known as statins, and all statins are P450 substrates. Again, this means that they all get broken down in the body, in the liver, by the P450 enzyme. Now, the different statins are broken down by that P450 enzyme to a different extent, some much more than others. So the statins that are metabolized by that enzyme to a high extent, such as simvastatin and lovastatin, will have the most potential for interactions with antiretrovirals. Because of this, all protease inhibitors and cobicistat-containing regimens are contraindicated with simvastatin and lovastatin. That's because PIs can increase the levels of these statins by 2,000%. This can be extremely dangerous for the patient. Non-nukes can do the opposite. Non-nukes can actually reduce statin levels, making them less effective at lowering cholesterol. So how do we manage the drug interactions between PIs, cobicistat, and the statins? Well, you'll see from the chart on this slide, I've listed the statin name, the interacting antiretroviral drug, and the prescribing recommendation from the DHHS guidelines. I've included this for you to be used as a reference. You'll see that importantly, lovastatin and simvastatin are contraindicated, and some of our other statins are safe to use, while some statins may have a dose limitation. For example, do not exceed 20 milligrams of atorvastatin or rosuvastatin with darunavir-based antiretroviral therapy. I think it's important to be aware of this interaction because some insurance formularies may only include certain statins and require a prior authorization to get one that does not interact with the patient's ARVs, but I've never had a problem getting this done. So this is the drug interaction wherein we usually change the statin to another statin if possible. Oftentimes we don't need to change the ART to compensate for this interaction, we just change the statin. The second major interaction I've seen often is drug interactions between antiretrovirals and anti-acid therapies. Now, there are many types of medications that can reduce stomach acid. These include over-the-counter antacids that contain aluminum, magnesium, or calcium carbonate, so things like Maalox, Mylanta, Tums, or milk of magnesia. There are also H2 blockers like ranitidine, which is Zantac, or famotidine, which is Pepcid. Some of these are also available over the counter. And there are proton pump inhibitors, which include omeprazole, which is Prilosec, and pantoprazole, which is Protonix, and many others. Some of these are available over the counter too. The problem with these anti-acid medications is that some of our antiretrovirals require an acidic environment in order to be fully absorbed. So if a patient takes an antacid medication that makes the stomach less acidic, then they may not fully absorb the antiretroviral medication, making the antiretroviral less effective. Some of the commonly used antiretrovirals that interact with antacid medications include atazanavir, which is an Evotaz and Reataz, and rilpivirine, which is one of the components of Complera and Odefsey. Lastly, our integrase inhibitors can have interactions with the aluminum, magnesium, or calcium-containing antacids. Now, integrase inhibitors do not require an acidic environment, so H2 blockers and proton pump inhibitors are okay. But the thing is, the integrase inhibitors work by binding to a pocket on the viral integrase enzyme that carries a positive charge. And if you remember back to your chemistry class in high school, aluminum, magnesium, and calcium all are positively charged ions. So if a patient taking an integrase inhibitor takes an aluminum, magnesium, or calcium-containing antacid, then the integrase inhibitor will bind to the antacid and won't bind to the viral integrase enzyme, and in doing so, it won't work effectively. Again, this interaction has nothing to do with stomach acid. It only has to do with the positive charge on the aluminum, magnesium, and calcium ions. So patients on integrase inhibitors can safely take H2 blockers and PPIs for heartburn. So this slide shows you how to manage the drug interactions between antacid medications and specific antiretrovirals, and I've included it to be used as a reference. In the first column, I've listed the specific antacid medication classes, the aluminum, magnesium, and calcium-containing antacids, the H2 blockers, and the proton pump inhibitors. And then if you move across the top of the table, I've put some of the most commonly prescribed antiretroviral medications that interact. Atazanavir, which is Reataz or Evotaz, rilpivirine, which is present in Complera or Odefsey, and the integrase inhibitors, the class as a whole. And so you'll see that both atazanavir and rilpivirine have significant interactions with all three categories of antacid therapies. Recall that this is because atazanavir and rilpivirine require an acidic environment for absorption. You'll notice that in specific instances there may be dose separation requirements, dose limits on the H2 blocker or proton pump inhibitor, and quite often the H2 blocker or proton pump inhibitor may be contraindicated. For integrase inhibitors, remember that that interaction is only with the aluminum, magnesium, and calcium antacids like Tums, Maalox, Rolaids, etc. This is because the integrase inhibitors bind to anything with a positive charge and are rendered ineffective. So you'll see there are specific dose separation requirements when any integrase inhibitor is given with one of these antacids. In most cases, the integrase inhibitor can be taken 2 hours before the antacid medication. And importantly, there are no interactions between integrase inhibitors and H2 blockers or proton pump inhibitors because, again, this interaction has nothing to do with acid suppression, but has everything to do with a chelation effect of the positively charged ions. But quite often in clinical practice, we just avoid giving these together altogether. It can be cumbersome for patients to remember the dose separation correctly, so more often you may wish to change a patient's ART if they require treatment with an acid-suppressing agent that interacts with their current therapy. And I proactively tell all patients taking one of the ARVs listed on this slide to avoid all over-the-counter versions of these medications and to call us if they experience heartburn and want to take something OTC, because these medications can compromise the effectiveness of their ART. Let's move on to a case study. A 45-year-old man with HIV infection has been stable for the last 5 years on an antiretroviral regimen of darunavir boosted with ritonavir and tenofovir DF-M-tricytidine. Despite changing to a healthier diet and increasing his exercise, lipid values remain elevated. Total cholesterol is 268, LDL 198, HDL 35, and triglycerides 220. He has a strong family history of cardiovascular disease, and his father had a myocardial infarction at age 52. The patient does not want to consider modifying his antiretroviral regimen, but he agrees to start lipid-lowering therapy. Which one of the following HMG-CoA reductase inhibitors, or statins, is contraindicated for use in this patient? A. Pravastatin, B. Atorvastatin, C. Simvastatin, or D. Rosuvastatin? The answer to this case study is C. Simvastatin. Patients with HIV carry a higher cardiovascular risk than non-infected individuals, and modifiable risk factors should be managed aggressively. Hyperlipidemia and hypertriglyceridemia are often adverse effects of protease inhibitors, especially ritonavir. In this setting, diet and exercise do not always have a significant impact on LDL reduction, and therefore, patients often require the addition of a statin. To some degree, all of the HIV protease inhibitors undergo metabolism by the cytochrome P450 system, and all inhibit cytochrome P450 system enzymes. Thus, concomitant use of protease inhibitors and statins can result in an increase in the level of the statin and enhance the risk for statin-related adverse effects, such as rhabdomyolysis. Significant drug interactions can occur when the concomitant use of a protease inhibitor and a statin. Simvastatin and lovastatin are contraindicated with all protease inhibitors. Atorvastatin, pitavastatin, pravastatin, and rosuvastatin are preferred statins in patients on ritonavir-containing regimens, with the caveat that with most statin and boosted protease inhibitor combinations, the lowest possible starting dose of the statin should be used, and the dose titrated upward to the desired dose while monitoring closely for signs of toxicity. Here's case study 6. A 34-year-old man was recently diagnosed with HIV infection. His baseline laboratory studies showed an HIV RNA level of 45,360, CD4 count of 425, and HIV genotype with no mutations. An HLA-B5701 test is performed and is negative. His other medical problems include hypertension, gastroesophageal reflux, and depression. He currently takes lisinopril 10 milligrams once daily, omeprazole 40 milligrams once daily, and escitalopram 10 milligrams once daily. Considering potential drug-drug interactions, which one of the following antiretroviral regimens would be most appropriate for this patient? A. Rilpivirine, tenofovir DF, emtricitabine. B. Rilpivirine and abacavir lamivudine. C. Atazanavir, ritonavir, and tenofovir DF, emtricitabine. Or D. Darunavir, cobicistat, and tenofovir alafenamide, emtricitabine. The answer to this case study is D. Patients with gastrointestinal disorders requiring acid-suppressing therapy have a significant risk of drug interactions, and both atazanavir and rilpivirine potentially leading to failure of antiretroviral therapy. There are no major interactions with darunavir and acid reducers. The absorption of integrase inhibitors are not affected by proton pump inhibitors or H2 blockers, but it may be impaired by co-administration with antacids that contain polyvalent cations, such as alumina, magnesium, or calcium. Again, this is because integrase inhibitors may be chelated by these cations. Here are the references used in this section of the presentation. So to summarize the main key points here, ART is recommended for all patients with HIV. The goal of ART is to achieve and maintain an undetectable viral load less than 20 to 75 copies per milliliter and an increase in CD4 count, and these goals can be achieved by selecting an individualized antiretroviral therapy regimen and maximizing adherence to therapy. Initial ART is 2 NRTIs plus an integrase inhibitor or a protease inhibitor, or a non-nuke, just like Panda Express, 2 scoops of rice plus 1 main entree. And because ART presents a high potential for drug interactions, we should ask patients if they have had any medication changes at each encounter. This includes over-the-counter and herbal medications too. And remember, the Southeast AETC clinical pharmacists are always here to assist you with your clinical consultations. Now, I understand that drug interactions are complicated, and it's impossible to know it all. But what we all should be aware of is where to go for help. And here are some of my top 2 recommended places to look for help with drug interactions. The DHHS Adult HIV Treatment Guidelines have excellent drug interaction tables that are constantly being updated as new information becomes available. They can be accessed on the aidsinfo.nih.gov website. Another great resource is the University of Liverpool's HIV Drug Interactions website. This is also available as an app called HIV iChart for iPhone and Android devices. It's completely free of charge, and you enter in all the medications the patient is taking, both antiretrovirals and non-antiretrovirals, and it will compute for you a detailed list of potentially significant interactions. It's a very useful resource that can readily be accessed and used at the point of care. And best resources for HIV treatment and antiretroviral therapy include the DHHS guidelines, again found at aidsinfo.nih.gov, and our Southeast AIDS Education and Training Center pocket cards. Those can be downloaded for free at the website shown on this slide.